So this is where you need to see the diagnostic on your 12-lead EKG. And it is in the middle of your 12-lead at the top. This one actually says ECG override data quality prohibits interpretation. And the reason why that one is there is because you will see that more often than not. What you're looking for is a true diagnostic. This first one is otherwise normal ECG unconfirmed. Very common diagnosis on this 12-lead EKG. The middle one is an abnormal ECG unconfirmed. This patient, it says they have sinus tachycardia. They might possibly have a certain type of blockage, and it's an electrical blockage, not a mechanical blockage, but a right bundle branch block. The bottom one says normal ECG unconfirmed, and you will see this very frequently. So here are your red flags. This is what you as an EMT or an advanced provider are looking for. This first one here. You see the stars and it says acute MI suspected. That is an indication of an MI, and that patient must be immediately transported to a PCI center. The second one, acute MI suspected again. The difference between the middle one and the last diagnosis here is you may have a lot of information printed out, you may have a little information printed out, but these both say acute MI suspected. This right here is what you need to read in your 12 lead. You don't need to worry about anything else, just acute MI suspected or normal ECG unconfirmed or normal sinus rhythm, whatever it states, but your big red flags are acute MI. Okay, so again, if your 12 lead says acute MI, or it says STEMI in capital letters, transport to a PCI capable facility. And if possible, we need to transmit the ECG to the facility. All right, Protocol 35 is our dialysis and renal failure protocol. And in this protocol, there is no real treatment at the EMT or advanced level. Protocol 35, however, we do need to talk about that we do not want to take a BP or start IVs in extremities which have active working shunts or fistulas in place. We always consider hyperkalemia or an increased potassium level in all dialysis or renal failure patients. Okay, Protocol 36 is a hypertension protocol, and there is no real different treatment in here from your current protocols. Just remember that hypertension is not common, especially in an emergency setting. It's the body's natural response to pain or stress. However, a hypertensive emergency is based on blood pressure along with symptoms. Symptoms that suggest an organ is suffering damage, an MI, a stroke, or renal failure. It's very difficult to determine this in a pre-hospital setting in most cases, but aggressive treatment of hypertension can result in harm. Most patients, even with significant elevations in blood pressure, need only supportive care. Specific complaints such as chest pain, dyspnea, pulmonary edema, and altered mental status should be treated based on specific protocols and consultation with medical control. So remember in this protocol, systolic blood pressure greater than 220 or a diastolic blood pressure greater than 120, of course, is a hypertensive crisis. The BP must be taken every 5 minutes with a minimum of 3 sets, time permitting. Okay, Protocol 37 is your hypoglycemia diabetic emergency protocol. And no real change from your current protocols in the terms of treatment. Our EMTs will have the option of oral glucose if indicated, if the patient is awake with an intact gag reflex. Our advanced providers may establish IV and treat with dextrose 50% up to 25 grams IV or IO as needed, may repeat in 5 minutes. And of course, if there's no IV, our advanced providers can administer glucagon IM. For hyperglycemic patients, again, advanced providers, IV procedures and boluses of 500 milliliters may repeat to a max of 2 liters. Of course, you need to assess for fluid overload. Okay, Protocol 38 is our hypotension shock protocol for adults. It's broken down between hypovolemic, cardiogenic, neurogenic, and septic shock. And for all provider levels, we need to establish a blood glucose analysis to determine whether or not hypoglycemia or hyperglycemia is the reason for the patient's condition. Also, we need to determine whether or not spinal immobilization is required, especially in the instance of neurogenic shock. So for our advanced providers in hypovolemic shock, we need to establish an IV and bolus our patients at 500 milliliters IV or IO. We need to repeat to the effect of a systolic blood pressure greater than 90, max of 2 liters. For cardiogenic shock, our enhanced providers will establish an IV at a TKO rate. Neurogenic shock, our enhanced providers will establish an IV and bolus the patient, again, to maintain a systolic blood pressure greater than 90, a max of 2 liters. And same for septic shock. Our advanced providers will establish an IV, bolus the patient at 500 mLs, IV or IO, and of course maintain a systolic blood pressure greater than or equal to 90 millimeters of mercury. Okay, protocol 39, hypotension and shock pediatric. Of course, we need to determine whether or not this is trauma or medical. If we've determined it is medical, then we want to obviously do a blood glucose analysis. And if the blood sugar is greater than 60, treatment is supportive. If it's less than 60, we do want to consider, for our EMT up to paramedic level, consider oral glucose solution if indicated, if patient is conscious and can maintain their own airway. Okay, just some notes on blood pressures in pediatric patients. Birth to 31 days old or a neonate, the blood pressure should be greater than 60 millimeters of mercury. 31 days to 1 year of life, the blood pressure should be greater than 70 millimeters of mercury. And 1 year and older, we use the algorithm of 70 plus 2 times the patient's age in years for a normal systolic blood pressure. Okay, protocol 40 is the nausea and vomiting protocol. The first question you need to ask yourself as a provider is, are there serious signs and symptoms of hypotension, poor perfusion, or shock? If the answer is yes, then at the advanced level, you need to establish an IV, consider 2 large bore sites, and administer normal saline boluses, 500 mLs, and you can repeat as needed up to 2 liters to obtain and maintain a BP of 90 millimeters of mercury or greater. And then you can treat your patient with the ondansetron or Zofran at 4 milligrams IV, IO, or IM. If there are no serious signs and symptoms of hypotension, poor perfusion, or shock, then go ahead and treat your patient with the ondansetron at 4 milligrams IV, IO, or IM, may repeat times 1. If abdominal pain is present, we need to exit to the appropriate protocol. If no abdominal pain, normal saline IV TKO, and if the patient improves, we notify receiving facility and transport. But if no improvement from the IV, then we want to administer a bolus of 500 mLs and then a bolus of 150 mLs an hour.